right, here we go. This is going to be our review session on anti-epileptics. So let's get going. Today we'll be describing the clinical effects of anticonvulsants, particularly in overdose. We will be summarizing also the diagnosis and treatment of anticonvulsant hypersensitivity syndrome, also known as DRESS, and then also distinguishing it from Stevens-Johnson, which people often confuse the two of those. And then we'll review treatment modalities for these poisonings, which, to be honest, aren't necessarily the most interesting of things, but what can you do? There are some really repetitive, kind of common themes with anticonvulsant overdoses. One of them is that they virtually all cause CNS effects because that kind of makes sense because the brain is the target organ of anticonvulsants. Most commonly, they are sodium channel blockers, although there are some other mechanisms strewn in there, and some have multiple mechanisms. Some of these medications are not just CNS depressants. They can also cause agitation or seizures, or frustratingly, some combination of going back and forth between those two things. And rather than just kind of, if you were to go through Olson's, you'd see that for every single anticonvulsant, they'll have like a different word for sleepy. It will be sleepy or somnolent or comatose or what have you. So rather than just continuously restating, different words for sleepy, we'll just kind of focus on the things that, well, this is what makes this one different or special. One nice thing about the workup for these is that because neurology needs to know, serum concentrations of these medications for monitoring and guiding therapy, it does tend to be fairly simple to get drug levels back. So that's one nice thing about working these up. So without any ado, we'll start with the TLC drugs. Maybe some of you remember this band from when I was like a teenager. So sad about Left Eye. Anyways, what are the TLC drugs? So there are medications that are not on this list for which, there are case reports of, oh, this anti-epileptic caused like a seizure once or whatever. So I'm not saying that these are the only drugs that can cause a seizure that are anti-epileptics or anticonvulsants, but the ones that are most commonly associated with causing seizures are these ones. We'll start with topiramate. So topiramate or Topamax can cause seizures and agitation and overdose. It also is a carbonic anhydrase inhibitor, which means that it's going to make you urinate out your bicarbonate, which is going to give you a non-anion gap metabolic acidosis. You can also see liver injury with a topiramate overdose, although certainly not as bad as, some of the other things we deal with. And the symptoms can be somewhat prolonged, lasting several days. There isn't much in the way of specific care for topiramate, which is honestly true of a lot of other anticonvulsants as well. If someone seizes from a topiramate overdose, we don't give Keppra, we give benzos, just like other tox seizures. If you want, you can treat the non-anion gap metabolic acidosis with bicarb, but depending on how the patient's doing, that might not be necessary, but it's probably not going to hurt. So tiagabine is more obscure. There's not a lot of people on this compared to some of the other drugs that we talk about. It is a fast onset and short acting anti-epileptic device or drug. And let's pause here and redo that. It is a fast acting and a fast onset and short pause. Let's try that again. It is a fast onset and short acting anticonvulsant. It can cause both CNS depression and agitation and seizures. It is potentially dangerous in that it can make you symptomatic and need to come to the hospital, but unlikely to cause death. I couldn't find very much in the way of case reports of people dying from a tiagamine overdose. And once again, if you seize from an anti-epileptic, consider giving benzos and supportive care. Lamotrigine is a little more interesting. So lamotrigine is serotonergic. And then because it's a sodium channel blocker, it also carries the potential for QRS widening and cardiac arrest. Um, it's not completely clear that giving bicarbonate will correct that QRS prolonging, although if you see a patient who's overdosed and has QRS prolongation, you should still give bicarbonate just to, in case it is a drug that would respond to that. We're not really sure what works in terms of enhanced elimination. I can say these patients are clinically they're kind of a little bit distinct. They in particular seem to kind of alternate between being comatose and virtually unresponsive, and then having episodes of agitation, and their pupils are dilated, and they might be tremulous from the serotonergic effects. They can kind of go back and forth between the two. So they can be a little frustrating to deal with just because, 1 second you'll be sedating them and then the next moment you'll be thinking that they're over sedated. So they can be challenging to manage from that standpoint, but um, otherwise, same idea as a lot of these other anti-epileptics. Carbamazepine. So this is another anti-epileptic that can cause seizures and overdose. As you can see from its structure, it is very similar to tricyclic antidepressants. Uh, Poisoning can be severe with this and can last several days, but it's only rarely reported to cause death. So, owing to its TCA-like structure, it is anticholinergic, just like TCAs are. It can also cause hyponatremia. And once again, this is one that can go back and forth between excitation and seizures and CNS depression. Because it is also a sodium channel blocker, it is possible that it can cause a sodium channel blockade. You can use multi-dose activated charcoal to enhance elimination. And in severe poisoning, it is also reasonable to consider hemodialysis. You can also do both. This is one of those drugs that, in theory, you could do charcoal hemofiltration on, but in practice, that is a rarely available modality because no one carries the filter that you need to do charcoal hemofiltration. Then there's oxcarbazepine. So the thing about oxcarbazepine is it's a less toxic version than carbamazepine. The reason why is you can see that oxygen double bound to the carbon at the top of the middle ring there. Um, that's the difference between this one and carbamazepine, which does not have that. This oxygen blocks the formation of an arine oxine metabolite of carbamazepine, which is more toxic than parent carbamazepine. So for that reason, it tends to be less dangerous than carbamazepine. I'm sure there's some pharmacologic reason why people still are put on carbamazepine, but from my perspective, why don't they just put them all on oxcarbazepine, right? There's probably a reason for it. It's more likely to cause hyponatremia. That's about the only other thing about it that's worse than carbamazepine. But in general, this one bothers me less than its closely related drug. Unlike carbamazepine, it is not cleared by hemodialysis. So if you see oxcarbazepine, think carbamazepine light. Gabapentin, this one is listed as an anticonvulsant. It's an adjunctive medication, so it's rarely used to treat seizures by itself. The name is deceptive. It's called gabapentin because it basically looks like a GABA molecule with a five-sided carbon ring attached to it, hence the pent. But it's not a GABA agonist, despite that, which is a common misconception about it. It is also written prescribed more frequently for neuropathic pain than it is for seizure use, but we'll still cover it here. And then sometimes it's used as an anxiolytic. It is not in the TLC drugs. and it is much less likely to cause seizures than the TLC drugs that I mentioned previously, but there are some rare case reports. Much more common is just CNS depression. Gabapentin is known for potentiating opioids. So, when combined with whether it's a illicit or an illicit opioid, it increases the likelihood of respiratory depression. It also increases abuse and is like co-abused with opioids. So it's it's a controlled substance because of that. You can withdraw from gabapentin, but the withdrawal doesn't tend to be dangerous. It's mostly just subjective. In terms of a single agent ingestion, it is unlikely to cause death. And the only situation in which you might consider dialyzing someone with a gabapentin overdose is if they have renal insufficiency. Otherwise, unlikely to be worth it. Pregabalin or Lyrica is mechanistically very similar to gabapentin. The toxicity is very similar, with the addition that it causes like a myoclonic kind of jerking, which can be mistaken for seizures. And also, it is not a drug that should be dialyzed. Phenytoin. This used to be so much more common back in the day. When I was a resident, when someone had a new onset seizure, they all got loaded with phenytoin, and it's since been displaced by Keppra as the number one drug for generalized tonic-clonic seizures. The reason it got displaced is that it kind of has some suboptimal pharmacokinetics. Specifically, it's saturable first order kinetics, or basically zero order kinetics above a certain dose. So that means that people can get toxic from phenytoin just from like seemingly small dose adjustments that kind of push you over the line from first order to zero order metabolism. Although obviously, if you take an overdose of a bunch of pills, that can also give you toxicity. Because phenytoin is highly protein bound, which is another thing that makes it less than optimal as a therapeutic agent, levels may not correlate with the free phenytoin. So you might see people with very high phenytoin levels that don't seem very sick from their overdose, and vice versa. So sometimes a free phenytoin level can be more informative, although once again you're mostly gauging the severity based off of the clinical picture, and not just kind of being overly focused on the level. In general, I find that the role of getting serum levels in these anti-epileptic drugs, I mean, if it's zero, then well, it's not going to be that. And if it's not terribly high, then you're not going to anticipate perhaps a prolonged course. But other than that, you can't overly interpret these levels to say, well, above this is going to make you exactly this symptomatic, and so on and so forth. Back to phenytoin specifically, hypotension is possible. Death is unlikely. There have been reports of cardiac arrhythmias, but this has been, as far as I was able to determine, only following intravenous administration, not with a PO overdose. And this is basically just going to be pure supportive care to manage. Levetiracetam or Keppra. I have to hand it to the drug companies here. They made a really safe drug because people take tons of it and we administer tons of it, and it seems like seldom does anything bad ever happen. So kudos. So in a one case series of 82 pediatric exposure, there was no major outcome, no deaths, and one moderate outcome. Primarily, people get like kind of psychiatric side effects like irritability or anger. If you take a very large overdose, it's possible to have agitation or coma, but that's pretty rare, and once again, requires a very large amount of drug to get there. Hypothetically, dialysis would clear this drug, but because it's relatively benign, it's unlikely that we would ever need to recommend that. Valproic acid is a bit more interesting as a drug. And the reason it's interesting is that it has a kind of a unique metabolism. So valproic acid is basically a short-chained branched fatty acid. And it has multiple metabolites, but there are two that are of interest. And then they're called 2-NVPA and 4-NVPA. And one is made in the mitochondria and is relatively non-toxic, and the other is made in the liposome, and that one is toxic because it blocks your urea cycle. So, overdose of valproic acid or sometimes even therapeutic use can cause hyperammonemia because basically your body disposes of ammonia by joining it to carbon dioxide to make urea, and when you can't form that byproduct that leaves your body in your urine, you're going to have a big buildup of ammonia. Um, Valproic acid causes hepatotoxicity. If you were to look under the microscope, the buzzword is microvesicular steatosis. If you're wondering what that means, basically it means that there are tiny little fat globules inside the cell under a microscope, as opposed to big ones. Clinically, I'm not sure why that matters, but it's the sort of thing that shows up on like toxicology boards. The definition of macrovesicular steatosis is when the nucleus is displaced by the little globules of fat because they're bigger. So if they're tiny little globules of fat and the nucleus is in the middle, then it's just microvesicular steatosis. Also causes hyperammonemia. And when this gets really bad, it can be really bad. It can lead to fatal cerebral edema and multi-organ system failure. It might be the most dangerous or among the most dangerous of the anti-epileptics in overdose. So the way that we manage this, as you could see from the previous slide, if you get the VPA into the mitochondria, it's going to be metabolized to the less dangerous metabolite. And the way that VPA gets into the mitochondria is using the carnitine shuttle. So the way that we treat this overdose is to give people IV carnitine because that's going to encourage the less toxic metabolite. If patients have severe toxicity, including coma, hyperammonemia, or high VPA levels, that's recommended. Usually that correlates with a serum concentration of around 400 to 450 or above that. But if there's end organ damage, um, I would be inclined to give it anyways. Carnitine is a vitamin. It's not a very dangerous um, uh, medication. So I would have a low threshold to giving it if a patient has significant symptoms. I don't know if it's technically vitamin, but I think of it as a vitamin. It's something that's necessary for your body and that your body is certainly used to seeing and having around. So if you have a very high level, then you can consider dialysis. It is recommended with a level above 1300, or if there's shock, or if there's cerebral edema. If there's merely acidosis or hyperammonemia or coma or a level above 900, then it is suggested but not recommended according to XTRIP guidelines. Next up is zonisamide. We're not really sure how this medication works, but like topiramate, it is a carbonic anhydrase inhibitor, so it's going to cause you to urinate out your bicarbonate and have a non-anion gap metabolic acidosis, which can be treated with bicarbonate if it's felt to be helpful. Has a very long half-life, so if the half-life is 2 days, that means a significant overdose can last almost a week, you could see. In fact, we had a pretty famous, locally famous case here that where basically the patient had a brain death sort of presentation, and I remember rounding on this patient, and it was I think 4, 5, 6 days in before she started to wake up, and there was a consideration of donating her organs, which obviously it's very good that that did not happen. There's no specific management here other than just wait for the person to wake up. It's not like you can do anything to accelerate the clearance. There's no antidote, but it's very important that you don't let a patient's organs get harvested. because the people didn't give them enough time to metabolize away their zonisamide. Lastly, I'm going to cover one of my little pet things that I like to talk about, which is differentiating Stevens-Johnson syndrome and TEN, or toxic epidermal necrolysis, versus DRESS, which is drug rash with eosinophilia and systemic symptoms. So if you're just going to look at the rash, it's they're different, but they're both pretty nasty rashes. And hey, we're talking to people over the phone, right? So there's a very good chance we don't get to look at the rash to help sort out which is which. If you're wondering, on the left is Stevens Johnson, and then you see sloughing of the skin on the letter B picture on the left side that you would be concerned about, like TEN, or toxic epidermal necrolysis. And on the right, those are DRESS rashes. So that's drug rash with eosinophilia and systemic symptoms. The reason these often get confused and conflated, both occur with anti-epileptic drugs, and a similar list at that. Of course, there are other drugs that can cause DRESS and other drugs that can cause SJS, so it's not like only AEDs, but AEDs are among the more commonly prescribed medications that are known to cause it. Both have really bad rashes. Both can kill you. For DRESS and SJS, mortality rate is about 5 to 15%. It can be upwards of 40% for TEN, which is the more severe version of SJS. So they have a lot in common, but they're not the same. And crucially, they are not treated the same. In terms of the underlying etiology, so we don't really understand very well how SJS works. There's a lot of theories out there, but nothing really solid at this point in time. We have a better sense of how DRESS works. These epileptic drugs can have these epoxide intermediates. That's when you have, usually it's a benzene ring, and basically an oxygen joins and makes like a triangle shape at, at a point on that benzene ring. And this is like an intermediate metabolite. And in most people, that oxygen bond is going to be hydrolyzed and just turn into an OH, which is fine. Some people are thought to be deficient in the enzyme that that cleaves that epoxide group. And if you just leave it lying around, it's very immunogenic. That leads to hapten formation and T cell activation. You get this big old angry immune response. For Stevens-Johnson, the drugs that are best known to cause it, that are anti-epileptics, that is, are phenytoin, carbamazepine, and oxcarbazepine. Lamotrigine and phenobarbital, as you can see with DRESS, very similar list with carbamazepine, phenytoin, and lamotrigine. So very similar drugs causing these two. It's not going to be a big help to try to sort out which is which. There's significant overlap with the time course involved with these reactions. But DRESS syndrome is on the longer side of 2 to 8 weeks compared to Stevens-Johnson, which is 1 to 4 weeks. The next slide, I think, is the most helpful for distinguishing between the two. So Stevens-Johnson is almost purely a skin disorder. You can get acute kidney injury, but that has to do with volume loss secondary to losing your barrier of your skin, rather than a direct nephrotoxic effect. And you can get some sloughing in other membranes through your body, but mostly this is a membrane problem. And it's a severe one, or can be a severe one, but it's basically isolated to the membranes, the mucous membranes, and the skin. Whereas DRESS syndrome is more likely to cause solid organ involvement and more likely to cause fever and lymphadenopathy because of its immunologic etiology. If you see a patient with a new hepatic injury, that to me really increases the suspicion that this is DRESS and not Stevens-Johnson syndrome. It's important to figure out which is which because the care is different. So with SJS being that it's primarily a cutaneous process, burn care is the primary sort of pillar of supportive care. And these patients are at high risk of sepsis because you lose your barrier, that is your skin, that helps keep out germs. So sepsis is sort of the big threat. And steroids are not routinely recommended for this. They do not appear to be helpful, although it's still somewhat controversial. Whereas with Dress syndrome, steroids are the mainstay of care. We're going to be giving high doses of intravenous steroids to suppress the immune reaction that is driving the end organ damage. Obviously, for both, you're going to do supportive care, and for both, this is very important, you're going to withhold the offending agent. And it would be prudent to withhold anything else that could also cause the same thing. Well, that's it for this talk. It's relatively brief because I feel like there's not a whole lot to say on anti-epileptics, but I'm happy to answer any questions, and thanks for listening.